Let's start with the introduction. Menopausal age of Caucasian women is reported between 48 and 55 years, usually occurring earlier in Asian women. In Europe, the average age is between 40 and 49 years. Recent studies across the world have thrown light on the increased cardiometabolic risks in postmenopausal women as compared to their corresponding premenopausal counterparts. Menopausal women may be predisposed to increase cardiovascular risk, possibly due to depletion in the ovarian follicles followed by subsequent reduction in estradiol concentrations. In addition, there is a deranged lipid profiles with alterations in low-density lipoprotein cholesterol, high-density lipoprotein cholesterol, triglycerides, total cholesterol, and also reduced glucose tolerance have also been previously reported in this group of women. On the other hand, as compared to the postmenopausal phase of the woman, secretion of estradiol in premenopausal women may offer a cardioprotective effect. In this slide, we can see the factors that improve or they are responsible for insulin resistance, which are obesity, inactivity, genetics, aging, medications, and some rare disorders. All of these factors result in insulin resistance, which further causes type 2 diabetes, polycystic ovarian syndrome, atherosclerosis, dyslipidemia, hypertension. What is insulin resistance, or short ER? Insensitivity of the target tissues in the human body to the action of pancreatic insulin is regarded as insulin resistance. In premenopausal women, an increase in weight or abdominal obesity can result in insulin resistance. ER is often observed in menopausal women, maybe because of the changes in their hormonal status and fat redistribution, coupled with reduced adiponectin secretion. ER represents a decrease in the ability of insulin to stimulate glucose use. Pancreatic B or beta cells increase insulin production and secretion as a compensatory mechanism, while glucose tolerance remains normal. This has been pointed as a collective health problem affecting several age groups, especially menopausal aged women. Here are some pictures. The first one is ultrasound of endometrial hyperplasia. And this is the histological finding of hyperplasia. Now let's talk about endometrial pathology. Endometrial pathology represents a frequent finding in perimenopausal patients admitted to our gynecology department. It is often found not only in patients with abnormal uterine bleeding, but also in obese women and/or disturbed carbohydrate metabolism. Major modifiable determinants of insulin resistance, such as obesity and physical inactivity, have also been shown to constitute risk factors of endometrial pathology, leading finally to endometrial cancer. In premenopausal women, overweight may lead to insulin resistance, ovarian androgen excess, anovulation, and chronic progesterone deficiency. There are higher circulation concentrations of bioavailable estrogens from extraglandular conversion of androgens. Much has been said about the relationship between carbohydrate metabolism and endometrial malignancy risk in peri- and postmenopausal patients, but not enough said for benign endometrial pathologies such as polyps and hyperplasia. I will explain now about our study. The aim of it that we performed was to detect hyperplasia in obese perimenopausal patients with abnormal uterine bleeding. Also to determine insulin levels, to reach the HOMA index of resistance, and to determine the association between hyperplasia and HOMA ER. This was a prospective cohort study performed at the University Clinic of Obstetrics and Gynecology in our country, North Macedonia, over a period of 1 year. 100 patients with abnormal uterine bleeding during the perimenopause were involved. They were aged from 45 to 50, divided into 2 groups based on body mass index. The first group consisted of 50 patients with BMI above 30 or obese patients, and the second group consisted of 50 patients with body mass index under 30. And the control group were 40 asymptomatic patients. All of the patients went through a complete diagnostic procedure, which means gynecological and ultrasound examination. Fractional curettage with the histopathological diagnosis was performed in both examined groups with bleeding. Then they followed laboratory diagnostics performed at the clinical biochemistry department. After completing the results, processing of the received data was done. Here are our results. As we can see, here are the most parameters that we analyzed in the study. This first graphicon shows that the level of glycemia was the highest in the first group. The average glycemic value in the first group is higher and is 5.7. In the other 2 groups, it is between the reference value limit. In the second group, it is 5.1, and in the third group, 4.8. The difference between the 3 groups, according to the analysis of variance tests, is statistically significant. And according to the post-hoc Tukey test, the difference is due to the statistically significant difference between group 1 and group 3. The next slide shows a level of insulinemia. We can also see that these levels are highest in the first group. And here we show the HOMA HER, cutoff value is 1.8, and this index is highest in the first group also. Findings of hyperplasia simplex were 40.9% in the first group and 23.5% in the second group. Complex hyperplasia was found in 1.5% in the first group and none in the second group. Typical hyperplasia was found 5.9% in the second group and 3% in the first group. Endometrial carcinoma was found 2.9% in the first group, 1.5% in the second group. The average value of HOMA index of insulin resistance in the first group was highest, and it was 2.8. Endometrial hyperplasia was registered in the first group at 40.9%. The first group registered a significant association between HOMA ER and hyperplasia, and the risk of endometrial hyperplasia occurring was 8 times higher. The first group registered a significant association between glycemia and endometrial hyperplasia. High levels of glycemia increase the risk of endometrial hyperplasia occurring by 3 times. Now we will discuss about these findings. Perimenopause as a period must be investigated, especially if risk factors are present. Endometrial hyperplasia, thickening of the uterine lining, can be the first warning sign of a pathological process. The majority of endometrial hyperplasia cases regress spontaneously. Only 1% progress to carcinoma. Atypical complex hyperplasia has the highest neoplastic potential and progresses up to 30%. Risk factors are similar to those found to be associated with endometrial cancer. Obesity, diabetes, hormone replacement therapy increase the risk of endometrial hyperplasia. Still, evaluation of this pathology is important, as this is a frequent finding in gynecological practice. Every uterine bleeding in perimenopause must be investigated, especially if risk factors are present. Here is a picture of health risks of obese people. These are numerous and consist of ischemic heart disease, nephrotic syndrome, hypertension, brain stroke, some cancers, diabetes, skeletal disease, pulmonary hypertension, and etc. Hyperinsulinemia and insulin resistance are commonly found in women with endometrial hyperplasia. On the basis of obtained results, we could say that insulin can play an important role in the pathogenesis of endometrial pathologies. Besides some other mechanisms, in perimenopausal women, chronically elevated insulin concentrations contribute to ovarian androgen excess, which may cause anovulation and further progesterone deficiency. Insulin resistance is defined as the reduced biological effect of a certain amount of insulin after binding to the receptor. Insulin resistance is manifested by the decreased use and increased output of peripheral glucose. At the early stage of insulin resistance, pancreatic beta cells will secrete excessive insulin to induce hyperinsulinemia. When beta cells get exhausted, blood glucose levels continue to rise, ultimately leading to the development of diabetes. We looked forward the study of Janssen, and in this study, the incidence of hyperinsulinemia in the observation group was 70%, which is significantly higher than that of the control group, which was only 8%. According to the HOMA IR evaluation method, 80% of patients in the observation group had insulin resistance, which was significantly higher than that of the control group. Elevated HOMA IR was noticed approximately in 39% of cases with non-atypical hyperplasia. As a conclusion, we can say that insulin resistance and carbohydrate metabolism disturbances are common in women with endometrial pathology in perimenopause. In the case of women with abnormal insulin resistance markers who experience pathological uterine bleeding and/or abnormal endometrium in transvaginal ultrasound, there is a clinical basis for recommending modification of lifestyle. What does it mean? It means a change of diet, balanced nutrition, more physical activity, adding pharmaceutical insulin sensitizing agents, which additionally can have an anti-proliferative effect on the endometrium. And at the end, however, more studies on this subject are needed. Thank you for